Hello, my name is Thea Newman and I am the Director of Solar Avis. This video is part of a series on the impact and efficacy of the COVID vaccination program in the UK. In this video, we'll be testing the robustness of the dataset used by the UK government in reporting mortality rates for the English population. The reason this is necessary is because 10 million people over the age of 9 are excluded from that official dataset. In this video, I'll show you how we can estimate the mortality rates within that 10 million population and compare them to the larger population that is used for the official figures. First, a quick outline of the presentation. I'll briefly talk about the databases that the ONS uses to calculate mortality rates, and then I'll go through in some detail how we can infer what are called crude mortality rates for individuals that are outside that official database. There'll be a little interlude, a tale of two towns, which will help us understand some apparent statistical madness. And then we'll show the results, the main part of the presentation, for the relative mortality rates for individuals who are outside of the official database compared to individuals who are inside the official database. And I'll end the talk with summary and comments. So moving on then to talk about the database that the Office for National Statistics is using. It's something called the Public Health Data Asset, and it combines data from the previous UK census in 2011, from general practitioner medical records and also from hospital records. And the ONS states that this database covers approximately 79% of the English population of individuals aged 10 and over, and actually accounts for over 85% of the deaths in the period January 21 to May 2022. The aim of this study is to look at individuals who are not captured in that public health data asset. That's a staggering 10 million people approximately. And I will show you how we can estimate the all-cause and COVID-related mortality for that other, as it were, hidden population. It's very important that we do this because we can then compare it to the official PHDA figures and ask how accurate and robust are those figures. Now let's see how we can assemble the data we need to estimate these mortality rates. So we're going to be using this table which looks at population size, all-cause deaths, and deaths involving COVID for the whole of the English population. This is excluding people under 10, the official database, the PHDA, and then the remainder, the 10 million people that are not captured in the PHDA. And from the ONS data set directly, we can actually list the all-cause deaths and the deaths involving COVID for the whole of England and within the official data set, because they do give all deaths in England in those two categories for the different age groups. Now, by simple subtraction, we can then fill in these two columns for the non-PHDA population, simply subtracting these columns from these. What we need now, though, is to fill in these population columns, and that's where we have to start making estimates. So, in the official database over this period, January 21 to May 22, the ONS gives figures what they call person years, and this is a statistical definition. It's number of individuals times the amount of time they're in the study. And because the study is 17 months, if we take this person years and multiply it by 12 divided by 17, we can effectively get a count, an approximate count of the number of individuals typically in each of the age groups in the official database. We can fill in this column for the whole of England just by looking at demographic data. I've chosen to look at the 2020 demographic data just because I felt that was at the beginning of the study, as it were. These numbers will of course shift slightly over the 17-month period, but again we're just looking to be creating estimates here. And so these are just taken directly from ONS demographic data. And again, we can now fill in this column by simple subtraction. Now do note that these population figures are in italics, and the reason for that is they're not to be taken too literally down to the exact individual. These are estimated figures, whereas the death numbers are actual numbers that correspond to individual death certificates. So we have everything we need now actually to calculate what are known as crude mortality rates for each age group. But before we go ahead and do that, let's just look at the totals, which I've got in the bottom row here, and compare the PHDA population and the non-PHDA population. And what you can sort of see here straight away is if we look at the youngest age group, in the non-PHDA population, that's over half of the total, whereas in the PHDA, the youngest age group is almost a third of the total. So it's a much younger population here in the non-PHDA, and that's going to be absolutely critical in what follows. If we just go straight ahead and look at the totals, we find that the estimated population in the PHDA is indeed approximately 79%, as quoted by the ONS. And we can also look at death rates, all cause and COVID, and they're around 86%, which is also what the ONS has quoted in their official figures. So we can be fairly confident that these numbers are good estimates, at least in the totals. Because these deaths are larger than the population by percentage, it means that there are essentially more deaths per population in the official database than in the hidden 10 million, as it were. And in fact, you can easily work out that the crude mortality rate for the total population in the PHDA is 1.7 times higher than that in this hidden population. But as they say, spoiler alert here, we're actually going to find that 97% of this population have higher mortality rates than their age group peers here. And you're going to say, how is that possible? And this is some of the madness of statistics that we'll now address with a cartoon before we get back to the important business of plotting mortality rates from this dataset. And now for a cartoon to show how strange statistics can be sometimes. Let's visit the inhabitants of Lamchester and Sheepton. So we're going to see from this little sort of cartoon story how strange statistics can be, even for very, very simple situations. So welcome to these two towns. We have Lamchester, which has 1,000 people, but they're mainly young, 900 young people, 100 old people. And then Sheepton, a neighbouring town, which is mainly old, 1,000 people, but 100 young people and 900 old people. So the population structures in these two towns are sort of opposite of each other. Now you don't want to live in Lamchester because, let's say, they have something terrible in the water, and actually the mortality rate for both young and for old people is double what it would be in Sheepton. So the mortality rate for young people in Lamchester is 2%, whereas it's only 1% in Sheepton. And the mortality rate for old people in Lamchester is 20%, double what it is in Sheepton. So whether you're young or old, you don't want to live in Lamchester because you have double the risk of death. However, if we were to calculate the total mortality rates for these two towns, you might have a different impression. So let's see, in Lamchester, the number of deaths in a year would be 2% of the number of young people, so 2% of 900, and 20% of the old people, 20% of 100. So we have 18 deaths in the young population, 20 deaths in the old population, leading to 38 in total. So the crude mortality rate is the number of deaths divided by the population, and that would be 38 divided by 1,000, which we could say is 3.8%. Now in Sheepton, the number of deaths would be 1% of the young population, 1% of 100, and then 10% of the old population. But you see we have quite a large old population there, 10% of 900, which is 1 plus 90 is 91. So the total mortality rate in Sheepton is 91 divided by 1,000 is 9.1%. So if you only knew the total mortality rates for Lambchester and Sheepton, you would avoid Sheepton like the plague and want to live in Lambchester, because it appears that the mortality there is a third of Sheepton. However, that is really just an illusion that comes from the fact that the total mortality rate is almost meaningless. In each of the two age groups, the mortality rate in Lambchester is double that of Sheepton, and you definitely want to live in Sheepton in terms of mortality. So a little cartoon that shows you how crazy statistics can be and why those total figures for population and mortality are actually not very meaningful. We need to dig deeper and look at age groups, which is what we will do now. So we learn that age structure is critical. Let's calculate this now for the 10 million population and work out these relative mortality rates. So we've learned that we have to first of all understand the population structure or the age structure to get a sense of the mortality rates. So what I'm plotting here from the table is the percentage of individuals in the official PHDA database and the remainder, the non-PHDA group, the 10 million, but I'm splitting it up by age group, and this is as a percentage within each age group. Now the average is 78.3%, but what you can see is that for the very youngest age group, there are a lot more individuals in the non-PHDA group. The same is true for individuals in their 40s, and then for 50s and above, actually the majority, beyond the 78.3% average are in the PHDA. So we have typically a younger population in the non-PHDA population. And that difference in the age structure is going to create a very, very different outcome when we look at mortality rates by age group. Just very briefly, I'll show you the same plot for all-cause deaths, where again you can see that the deaths do not follow the straight average of the population. The total average we saw of deaths was 86%, but you can see that much greater percentages of individuals in these younger age groups are counting towards that mortality in the non-PHDA population. And this is even more stark, actually, if you just look at deaths involving COVID. So it's a bit hard to put these three graphs together in your head. So what I'm going to do is take these blue bars of population for the hidden 10 million group, the all-cause deaths in orange, and the deaths involving COVID in red, and plot all of those together on one graph, and this now will make things much, much clearer for us. So we're now only looking at the non-PHDA individuals, the 10 million that's not included in the official statistics, and we're looking within each age group at what percentage within that age group are in this non-PHDA versus the PHDA. And you can see that in the very young, we have over 21% in the young group there, slightly over 21% in the 40s, and then below that, so again, a sort of a younger group. But what I want you to see from this figure is something much more important, which is that as we go from the younger to the older age groups, we see that a gap appears, this is crucial now, a gap appears between the population and the deaths. What you can see here is that in every age group, the proportion of deaths is higher than the population size would indicate until you get to the 80s and 90s. That gap is particularly large for people in their 40s and people in their 50s. So what we can do now is simply calculate crude mortality rates for the PHDA group and the non-PHDA group. And the way I'm going to show you this data for each age group is to look at the mortality rate in the hidden 10 million group, subtract from that the mortality rate from the official database, and then normalize it by that same number. So these are basically relative mortality of the hidden 10 million compared to the PHDA, but expressed as an excess, so it's relative to the official mortality, and I'll convert it to a percentage. So here we have this for deaths from all causes for each age group. And what you can see is that the excess mortality in the non-PHDA, or I'm sort of calling it colloquially the hidden 10 million, the excess mortality there in each age group is higher, is a positive excess of mortality, except for the two oldest groups. This excess mortality can be as high as over 60% for people in their 50s. When you work out what proportion of that non-PHDA group is in these ages up to the age of 80, it's about 97% of that population. So 97% of the non-PHDA population have excess mortality compared to their peers in the PHDA population. For COVID, it's even more stark. We find that actually even individuals in their 80s have a slightly higher mortality compared to their peers in the PHDA group. I'll show these two together. I'll show the deaths from COVID alongside the deaths from all causes. So these green bars above the line, the excess mortality, accounts for actually 99% of the non-PHDA group. So in terms of deaths involving COVID, 99% of individuals in the age groups of non-PHDA have higher mortality relative to their peers in the PHDA. So these really are very, very stark statistics. You can see that particularly for people between the ages of 40 and 70, this excess mortality is very, very large. 50% higher up to almost 80% higher. So very, very stark and important, and sobering to think that this is neglected in the official figures. I'll summarize the main results and make a few concluding comments. This has been a slightly mind-bending journey through mortality statistics, but the results are very important, I believe, and I'll summarize them here for as much clarity as possible. The takeaway message is that the non-PHDA mortality rates by age group differ greatly than those in the larger official PHDA database. Our analysis has provided the following estimates, and these are estimates because I don't have exact population figures, but I would say that these are pretty robust numbers. The non-PHDA mortality rates for all-cause deaths are higher than those in the official population, the official database, in all age groups except 80 and above. This translates to 97% of the non-PHD population have higher all-cause mortality rates than their peers in the PHDA population. In COVID, it's more stark even that those mortality rates in the non-PHDA group are higher than the PHDA in all age groups except 90 and above, the very highest age group. And this translates to 99% of the non-PHDA population has higher COVID-related mortality rates than their peers in the PHDA population. I want to draw particular attention to the age groups 40 to 70. Because there we see that the excess mortality can be, well, is always higher than 50%, can be as high as 80%. So individuals in those age groups having almost double the mortality rate compared to their PHDA peers in that age group. I find that quite staggering. A slightly more subtle point is that the degree of excess mortality from COVID is more severe than the all-cause mortality for every age group except the very youngest, where actually the difference is negligible. So this This stark excess is always worse for COVID-related deaths than it is for the all-cause deaths figure. So let me just make a few comments. It is pretty clear, because of the large differences, that if the non-PHDA population mortality, so the deaths occurring in that 10 million population, were to be included in official mortality rate figures, those figures would be shifted significantly. One can estimate that some of those figures would shift by almost 20%. I think more importantly is the fact that, particularly within the 40 to 69 age group, these very greatly elevated mortality rates in the non-PHDA population must be a great concern in terms of healthcare provision and well-being. Remember, this is 10 million people that we're talking about, and if there is a significant group of that 10 million that has 50% up to 80% higher mortality, this has to be something that is scrutinized very, very rigorously. Something that we haven't been able to address here is how do these large differences in mortality rates filter down to the different vaccination status groups, which actually is our main interest in this series of videos. And that's something we can't address here because we simply don't have the data for such a study. There is a serious risk that these 10 million individuals in the non-PhD population become what you might call the far side of the moon in English healthcare statistics, something that we know is there but is simply not observed, and maybe is lazily assumed to be similar to the thing that we do observe, whereas actually what we find here is that there are very grave and stark differences in mortality rates in that population. The data that I've used here can be found at these websites. I would like to thank colleagues for discussions, in particular H. Newman, who has assisted me with some of the data checking. Any errors that are in this data are solely my responsibility. Quite a stark outcome from this investigation. In trying to achieve precision, which in turn leads to them neglecting 10 million people in the English population, the government is failing to achieve accuracy. This is particularly sobering because within that 10 million population we see that generally mortality rates are higher in each age group. In some age groups, the middle ages, quite a lot higher. That group needs more detailed study, not to be neglected. So, a better compromise needed, I think, in the government between precision and inclusion in their reporting on COVID data. Thank you, as always, for your attention and your time, and I will see you in the next video.